Good morning, everyone, and welcome back to Monty Hot. This week, we're doing part two of our dry coated balloon update. So last week, we talked a lot about the actual balloons, how they made, the science behind it, and how not all drug coated balloons are equal. And this week, we really want to take you a little bit into depth into sort of the lesions we treat, the data behind different lesions, and talk also about how to use drug coated balloons. So again, me and Pierre will do this. Thank you for joining. We've given everybody, just about everybody, access to talk. So please feel free to stop us, ask questions. We want to make this as interactive as possible. So, Pierre, let's go.
Yes, absolutely. Good morning, everyone. And I think we can go ahead with the second part of DCBs. And I think we can start off with a simple question. So we have a DCB, how do we use it? Well, and how, I think number one, it's important to understand when. Uh, and in terms of clinical and angiographic indications, we have now some OGs, some like in-stent restenosis, and some that have been, mostly appreciated overseas, such as small vessel disease in de novo, and others are coming up, and some observational, and some also prospective randomized studies have been introduced lately on de novo lesions in vessels irrespective of size. So some other long lesion data, bifurcations, CTOs, and all of these indications in terms of angiography are really uh, aiming in a way to make simple what could be procedures that are rather complex when implementing two-stent strategies in complex calcified lesions. And I think the reasoning behind this is really to make sure that we try and keep things simple. And whenever we look at patients, actually, on the other hand, I think clinically, there are some people that might benefit from drug-coated balloon angioplasty rather than straightforward stenting, which are especially diabetic patients, patients at high bleeding risk, so patients that cannot tolerate long-term dual antiplatelet therapy, and sometimes and recent data has been also implemented in patients with acute coronary syndromes and STEMIs included. And in terms of then when we go and use DCBs, well, it's really key, and I think we're gonna really highlight this aspect throughout the presentation. It's really key to make sure to have appropriate lesion preparation. We're gonna see with Dr. Latib in just a second a little bit more on that. And really, I don't think there's any restriction as far as any device to be utilized for lesion preparation, as long as we really do gain uh, nice acute lumen gain. Normally, this has been discussed plenty of times by experts, including Dr. Deeb and Dr. Scheller from Germany, and a whole team of historic people that really try to understand what's a good cutoff in terms of person diameter stenosis to say, well, if we reach that level, then the probability of actually having a restenosis at that point, and that segment that's been treated is actually low. And it's been discussed plenty of times, and the experts have looked into an indicative percentage of diameter stenosis, 30% being satisfactory in terms of the angiographic result. And then, of course, we can have a little bit more detail on what's the mechanism of any residual percent diameter stenosis. Is it recoil? Is it suboptimal acute gain due to calcified lesions? And another aspect that it's really important to take into consideration is how the blood is flowing in that segment and distally. So any TIMI flow less than 3 is really something that should be very, very well recognized. And any flow limit in this section should also very, very importantly kept in mind. Oftentimes we're going to see dissections, and oftentimes these dissections might also look scary. And I think it's, and Dr. T, please uh, confirm, but I think it's really kind of a return to a balloon angioplasty era if we want to go ahead and really go and use DCBs again, especially in de novo lesions. And in terms of whenever we decide the device itself, we have prepared the lesion, we have seen the result of lesion preparation, we're satisfied in terms of efficacy, and we're satisfied in terms of safety. Well, then the only thing, and we touched upon this, the only thing that we expect for a drug-coated balloon to do is actually just to deliver the drug. So we just bring in a drug-coated balloon that's size 1 to 1 to the vessel. It covers the whole lesion length that we treated. So usually it's 2 millimeters on each side, and it's inflated there enough time for the drug to actually elute or go from the balloon to the lesion site. And of course, if anything happens in the middle of this procedure, from lesion preparation until also after drug-coated balloon angioplasty, well, we always need to keep in mind that we always have drug-eluting stents that can really help us in case anything goes south.
Yeah, so I agree with a lot of that. Maybe if you go back just a sec, I would just maybe add that, just a couple of things. So the residual diameter stenosis less than 30. This is an angiographic evaluation, so it's not QCA. It's just you looking at it and say that looks like a good balloon result, right? And we know that generally as interventional cardiologists, we are not great at evaluating diameter stenosis. We grossly overestimate diameter stenosis. So we call what sometimes on QCA would be 70, 80, or 90, but then you do QCA at 70. So we wanted to give ourselves a more stringent task and say, because we tend to sort of overestimate it, that's kind of why we went with 30%. We really wanted to be sure that you got as good a result as possible. The other thing that I think is underestimated as well, is the importance, and I'm going to show you some data, it's actually supported by data, is the diameter of the balloon being 1 to 1 and the inflation time. And if you remember, those of you who were here last week, it's the drug excipient, as you inflate the balloon, are then deposited onto the vessel wall in a very homogeneous way. But part of why you're actually leaving it for 60 and 90 is not just to get all that drug excipient off. It's already to get it to start moving into the vessel wall, and so that when you deflate the balloon, it doesn't completely wash away. Because if it was just like a powder you put onto the vessel wall, and then suddenly you deflate, that's just going to wash away. So you actually, by keeping it inflated, you're stopping blood from having contact with the drug excipient combination, and you allowing time for the drug to dissolve, or the drug excipient combination, or the microparticles, nanoparticles, if you're using sirolimus, to actually start moving into the vessel wall already. Okay, and so if you look at every IFU for drug-coated balloon, it says 60 seconds is the maximum time. You should do from 30 to 60. The reason the IFU say that is because they're very concerned about causing ischemia, and they don't want to put in the IFU that you can go to 2 or 3 minutes, because if you were then to have ischemia from the vessel being closed and you didn't do something simple like deflate the balloon, the patient has a VT or a VF, they would feel liable, the company would feel liable. Those of us who use these balloons, most of us will keep it inflated as long as we can. I mean, I've left the drug-coated balloon inflated 2-3 minutes in a proximal LAD, right? If a patient will tolerate it. So that's one important thing. The other important thing is, if you're doing a left main, and I've done many left main restenoses with drug-coated balloons, you have to try to get to 30 seconds at least. As you may get to like 20 and start seeing, oh shoot, the blood pressure is starting to go down a little. You're starting to see some ST changes. Try to get to at least 30 seconds, if possible, before deflating. If you have to deflate less than 60 seconds, and you haven't gotten to 60 seconds, we usually recommend inflating one more time with the same balloon, not moving and inflating it. There's a lot of discussion as to, does that work? I think it does with some balloons. You will get more drug delivered. It doesn't work with all balloons, but rather than them just think, is this a balloon? It will work or not, just do it with all balloons. So let's go to the next slide. So we spent a lot of time creating this sort of consortium or consensus group of experts who had a lot of experience with drug-coated balloons and have published extensively. And we've just kind of updated this. There's a DCB ARC document that's coming out in the next week or two that will have some updated data on, on how we evaluate DCB. But basically, when I think about doing a DCB case, right? I look at the case, I see the angiogram, I go, this would be a great case for DCB. I don't automatically open the drug-coated balloon. I first go through the steps of doing good lesion preparation, right? So what does that mean, good lesion preparation? And I often joke about this is, Michael, it's like we have to teach the younger generation how to do POBA, right? Because good lesion preparation for drug-coated balloons means knowing how to do good balloon angioplasty. Now, people who've been around doing this for a long time, we've done that or we've learned from people who've done that before. And I really wanted to spend a lot of time on this. And so I always say, when you pre-dilate and you're going to do a drug-coated balloon case, you have to do sort of POBA the old-fashioned way. Okay, and what does that mean? It means when you pre-dilate, I tend to use non-compliant balloons only. I try to go as close to 1:1 or 0.8:1 as far as sizing goes. I tend to use longer balloons. I don't use like 10, 12 millimeter, 50 millimeter balloons. I'm kind of trying to dilate longer segments. So I'll use like a 20 millimeter balloon, even a 30 millimeter balloon. And I do long inflations, right? So my inflation time is anywhere between 30 seconds and 2 minutes. The good thing about doing long inflation times is you also cause what's called ischemic preconditioning. So if you do multiple inflations before you get to a drug-coated balloon, the patient's going to tolerate the drug-coated balloon inflation much better because there's this concept of every time you occlude the vessel, okay, you precondition the myocardium, and the next time you occlude it, you can actually occlude it for a longer period. Okay, so patients tend to tolerate it better. So again, POBA the old-fashioned way. Non-compliant balloons, long, 1:1 or 0.8:1 if you're worried about, dissections, and long inflations. I then deflate, pull the balloon back into the guide, and I do a little puff to see. If I see a little bit of a dissection I don't like, I go back and I reinflate because one of the best treatments for dissections is actually repeated inflation, and I'll try and then just do a longer inflation. Okay. Then, depending on if I get a good result and there's no residual stenosis, I'm done. Okay, I then do my angiogram and I evaluate if I have what's called an acceptable angiographic result. And what does that mean? It means I want to have TIMI 3 flow, obviously. I want to have a diameter stenosis that looks less than 30%. If it looks like 50%, it means my work's not done. Okay, and I want to have a non-flow limiting dissection. So what does that mean? I don't want to see a flap. If I see a little bit of staining, the staining must wash away immediately. If I see a lot of staining or crater, then maybe I have a medial, a dissection that's gone into the media. That's not good. I really want a type A, type B dissection where it's maybe you see something that looks like there's a little flap there, but it's kind of gone. There's no staining. I mean, there's almost always dissections when we do angioplasty. I was always told if you're not causing a dissection when you're doing balloon angioplasty or when you're doing PCI, you're not doing good PCI, right? It's part of what we do. And if that stage I want to do imaging, or I'm thinking about doing imaging, that's the moment to do imaging. Okay, I'll do my IVUS. I tend to do more IVUS than OCT when I'm evaluating my balloon angioplasty result. And the reason being, and I'm sure Michael will attest to this, is you see less dissections. And the problem with OCT sometimes is you see a lot of dissections and then you go, oh, shoot, I can't leave that alone. I've got to cover it with a stent because you see even tiny intimal dissections. right? But if you're more experienced with OCT and you can say to yourself, I'm only going to worry about dissections that enter the media, I'm not going to worry about intimal dissections, I think OCT is fine. I do my imaging, I like the result, and then the last thing I do before I say I'm done with the case, okay, practically, is I go with the drug-coated balloon, okay? I inflate my drug-coated balloon then for at least 60 seconds, if not longer, okay? And I'm going to talk a little bit more about drug-coated balloons. I then deflate, take it out. I usually do an immediate angiogram in one view. If it looks good, I'll pull my wire back and I'll do a second angiogram in a orthogonal view. I think it's important. I maybe wrongly so, and Mark, Manigas on the line is probably going to go, you bad boy. I often do with my stents, my last angiogram may still have the wire in, maybe I'm a little lazy, but with drug-coated balloons, I always try and make sure that my wire is back for my last angiogram, because I have had cases where because we're just doing balloon angioplasty, there's no stent, the wire may be holding a dissection flap up, and by pulling it back, I actually see that. I also see less effects from spasm from the wire. So that's the way I do it. Then, if I can't with a non-compliant balloon get a good result, then I'm going to add specialty balloons, whether that's scoring, cutting, lithotripsy. Um, then people ask me about, what about rota? Have I done cases with rota followed by drug-coated balloon? I have, but it's not that common. When you kind of have cases where you have to do rota as well, it's the times I use drug-coated balloons, and we'll maybe have some examples when I'm doing very diffuse disease and I want to limit the amount of stents. But if it's like on a focal lesion and I'm doing rota, maybe I'm not using a drug-coated balloon. So let me see the next slide, Pierre. So this is again my very simple way of how to look at this, right? Other thing, just maybe on the repeated inflation, super important. And then the last thing I want to talk about, I've spoken to many of you about it, is how to use the DCB. And maybe it's going to sound obvious, but I'm gonna do it again. Is when you finally decide, you get to the point you're going to use the DCB. I open it. I have the tech give it to me still completely in the balloon cover. I pass off the back of it to the tech, and so that I have the front of it. I wait for the balloon to be prepped. I then only, when the balloon's prepped, pull off the plastic covering and the stylet inside. Okay, and I make sure I don't grab the actual balloon, right? When you're using a paclitaxel balloon, it's easier to remember because it looks white. When you're using a sirolimus coated balloon, it looks like a normal balloon. Okay, so a couple of things not to do is, hold it further back. Don't touch the balloon. Don't put the balloon in saline or in your saline flush. Don't liquor the balloon. Doesn't help to make it go quicker. Just try to hold it really further back. Load it on your wire, and I get it all the way to the co-pilot, and then I make sure my tech has the wire. Um, I look on Flora and make sure I'm on the right wire if I'm using two wires. I didn't do this recently with one of my fellows, and they put in the wrong wire, and then we had to throw the balloon away. So make sure it's on the right wire. Make sure the wire is still down the artery, okay, because that's happened too. And then I always tell myself, and remind myself that even if I do everything well, by the time I get the balloon to the lesion, and inflate the balloon, I'm gonna have lost 80% of the drug. So now imagine if I'm struggling to get the balloon to the lesion. So we talk about transit time, right? So the transit time from the time you go through your co-pilot and get to the lesion is super important. And you want to keep that time down to as minimal as possible. I want to keep it down to like 20 seconds, 30 seconds. Most of us would believe that if you're struggling to get the balloon down and you've had that balloon in contact with blood for 2 minutes, you might as well then throw the balloon away. Okay, it's no longer going to work. There's no drug left on it. There's not enough drug for it to be effective. Okay, so transit time is super important, and or dwell time is another word people will use for it, is how long the balloon's in contact with blood. So just think about that too. And then when you get there, you usually want to go nominal pressure. Sometimes you may go higher because you're doing a bifurcation and you want to be sure you're in contact with the proximal vessel. You need to be 1-to-1 and long inflations. I can't reiterate this enough. I've been in a couple of cases where I see the staff starting to panic because they're seeing a little bit of ST changes. They go, oh no, this ST changes, and they want to deflate the balloon. You just got to be patient. You got to give this balloon 60 seconds to work. Next slide. Let's maybe go to the next one. It's a little bit difficult to read, right? So is this impactful, right? Doing this for a longer period and pre-dilatation. So we years ago we were doing a lot of drug-coated balloons, but we noticed some patients were coming back. And they were coming back within 6 months or 9 months. And we tried to figure out why were they coming back. So we did this study that we published years ago, and this was looking at restenosis, but I'm going to show you another study from Korea that looks at all drug-coated balloons and shows similar data. So what we did was we looked at all our data and we said, like, why are patients coming back so soon, right? And this is when we became more and more aware that some of our colleagues were just, dilating the lesion, sticking the drug-coated balloon in, even if they didn't get a good angiographic result. So we did this study and we basically did it very simple. We said, let's divide the patients into those where there was a good angiographic result and those that there were not, that the result was not good. So what we keep talking about, TIMI-3 flow, residual stenosis less than 30%, no major dissection. Or the patients where there was residual stenosis less than 50% and separated them. And what we showed was that there was clearly a very significant difference. If you got a good result, you had better long-term outcomes. And the further away you were from the restenosis or the treatment, the better the outcome was. So the difference, we couldn't really, when we did the landmark analysis on the right, there was not much difference in the first year, but after the first year, there was a huge difference, right? So again, I just wanted to sort of highlight the importance of the angiographic result in getting good outcomes. It is so important. Now, there's another slide, maybe next slide. This is not the Korean one, but it's similar. I think we still have the Korean one coming. But again, yeah, another group looking at the same thing. They divided in red. Okay, those where you didn't have a good result versus blue, you had a good result. So in A, residual stenosis, yeah, they said less than 20% versus over 20%. Look at the difference in outcomes, right? Then they looked at things like such as the DCB to artery ratio. The closer you are to 1-to-1, the better outcomes. And then total inflation time, the longer you are, the better the outcomes. So again, clinical data to support that even though, this is nothing special, it's just a balloon. The preparation before you put it in is so important to the outcome you're going to have and also the way you use it, choosing the right size, long inflation times. Next slide. Then the other thing that's become also pretty apparent for me, and I don't know how often you guys do this, is the fact that when I treat restenosis, I have a very low threshold. I almost always, I think 80% of the restenoses I treat with drug-coated balloons, I use a scoring and cutting balloon. Now, why? Well, I think scoring and cutting balloons do give you controlled dissections. They give you all these advantages, more stability, more dilation power, more luminal gain. They decrease the dissection rate, but more just in a very simplistic way. If you think of like inside the artery, you have all this neointimal hyperplasia, right? And when you use a normal balloon, what are you doing? You're just pushing it to the wall. Maybe you're causing some cracks in it, but generally you're pushing it to the wall. If you use a cutting balloon or scoring balloon, okay, you actually scoring it. So you're making cuts into the neointimal hyperplasia. And so you can have drug that goes deeper into the tissue than you would without a scoring balloon. So one of my advices to you, many of us who have been treating restenosis for years love using scoring balloons and cutting balloons because it avoids the slippage, right? That sort of melon seeding effect. You inflate your balloon and boom, it jumps forward, it jumps backwards. but also it may have a particular effect. And I'm not sure if the next slide has the data on this. Can you go to the next slide, Pierre? No, come back. So, is there data on this? Yes, there's actually a randomized study called ISA Desire 4, where they randomize patients to scoring balloon followed by drug-coated balloon versus scoring balloon, sorry, drug-coated balloon alone. And interestingly, they actually showed a difference. They showed less late loss, less restenosis in the group that had scoring. So I don't think it was anything special about scoring. You could use scudding balloons too. But my advice to you is when you're thinking about restenosis to use a scoring or cutting balloon before you use the drug-coated balloon, I think you're going to get better outcomes. So let's go into some of the different lesion types. Next slide. Okay, go ahead, Pierre.
Oh, yes. So as we were saying,
We don't
in-stent
see you, Pierre.
restenosis,
Maybe you put your camera on.
yeah, I, I just went to get the charger. So I think we've back in the years we started with indication of in-stent restenosis, and still nowadays it's been the first that's been investigated in the United States with randomized studies, so the Agent IDE study. And I think that we always, as we also highlighted the other time last week, we always need to keep in mind that whenever we compare, and now randomized studies are being conducted and patient enrolled, whenever we compare DCBs and DES, well, we're comparing two different technologies. So we always need to keep that in mind. So I think that DCBs are really particularly attractive in bare metal stents ISR and multiple peristent layers, small vessel ISR. And whenever we have very relevant side branches that are emerging from the failed stent, and we're afraid that maybe implanting a second stent within them might actually go and impact flow and patency of that branch. Nonetheless, and whenever we have episodes of recalcitrant ISR, so ISR lesions are really repeatedly restenoting after DCB, well, then might be the case that a drug-eluting stent might actually be helpful. Of course, that might be a little bit more difficult if we have patients with a small vessel ISR. But at some point, if the drug-eluting balloon is not working, a second stent might be required. In terms of clinical example, this is just a 72-year-old patient that was post PCI in 2020, presented with non-STEMI in the ED. And you can really see over here a previous stent in left anterior descending artery. And I don't see a reason at this point to go ahead and implant a second stent first time that the patient presents with ISR and put a second layer stent. I know that also now, since there's been a meta-analysis, the Daedalus study a few years back, and this has been accounted for in the latest guidelines in Europe. Now, class 1 for drug-eluting stent ISR is the drug-eluting stent repeat PCI. But I think in this case, it's pretty reasonable to think about a stentless procedure and see how new delivery of drug via drug-coated balloon can really be helpful. So as Dr. Latib said, very good lesion preparation. This was a non-compliant 4.0 balloon in the mid to proximal AD, and then followed by a solution 3.5 by 30 at 10 atmosphere for prolonged inflation. And I think this really is something that we need to account, especially in first presenting ISR, even if drug-eluting stent ISR. This is some data just recently that we looked at differences between sex, so males and females, and apparently just like also in drug-eluting stent implantation, females do appear to have higher risk of target lesion vascularization, especially after ISR and DES. But I think this slide and
Maybe if you go back,
Dr.
let's
Latib,
finish.
yeah,
Let's just finish talking about restenosis because I
yeah.
think maybe just go back. Do you have the Daedalus study? You don't have that, do
No,
you?
I would just put this other one by Jacopo. I just want this one is the one that then
Okay.
I decided to put.
So
But
if you, I mean, even if you look at this one, right, and you look at the Daedalus, which is a randomized, which is a meta-analysis, clearly for BMS ISAR, drug-coated balloons in all the meta-analyses show a favorable outcomes. They're just as good as drug-eluting stents, right? When you look at DES ISR and you look at some of the randomized studies, um, drug-eluting stents did better than drug-coated balloons as far as TLR goes. Okay. Now, a lot of us who are in the field have a little bit of issue with some of these studies, and a couple of the things to kind of noteworthy was whether it was first restenosis versus a second or third restenosis. These were not matched or were not taken into the randomization. But most importantly, what was not taken into the randomization was the angiographic result before putting in another stent versus putting in a balloon. So the patients were in many of these studies, and the most important one is something called the study called RIBS 5. There was RIBS 1 to 6 done by some friends of ours in Spain. But in that study, you were randomized. You knew you had an ISR. You were randomized right at the beginning of the procedure. Right? So if you went into the procedure and you started dilating and there was a lot of neointimal hyperplasia, right? Maybe you were able to expand the stent. It wasn't stent under expansion, but just a lot of neointimal hyperplasia that despite multiple dilatations and cutting balloons, you still had a 50% lesion inside. And we've all seen those cases. A drug-coated balloon is not going to work there. Right. I think you need a stent there because you need to squash basically the neointimal hyperplasia between your new stent and your old stent. That's the only way you're going to get a good result. Also, they didn't take into account some of those studies, even though they were randomized, they were smaller. They didn't take, it wasn't balanced for the type of restenosis, diffuse versus focal. So the the European guidelines down for a long time had a drug-coated balloon as a class 1 indication for DES ISR. They recently downgraded that. They took away the class 1 indication. I think a lot of us still have concerns about that because, it's based on data that has some flaws, but also I think, it's not like stents are that much better. I think for most of us, we still feel uncomfortable about putting a second or third layer of stent, right? And you can always do that. So if someone comes back with a restenosis and you do a drug-coated balloon and they come back again and it's failed, you could then put a second layer of stent. It's not like you can't do it. You can do it later, but if you're able to treat their restenosis with just a balloon and they remain with one stent layer, I think, and I'm sure most of us agree, that's better for patients, right? Not having multiple stent layers. So I just wanted to maybe just give some context. I still believe one of the strongest indications for drug-coated balloons is ISR. In the rest of the world outside the United States, there's no longer brachytherapy. This therapy has replaced brachytherapy as the main therapy for ISR, and I believe there's still a very strong indication. Okay, let's look at the second indication.
okay, here we go. So went through ISR, and in order of time, I think the second kind of angiographic indication has been really the focus of drug-coated balloon angioplasty has been for a few years now small vessel disease. So on the right-hand side, actually, you can see the Andromeda study, which was very recently published just a few months back. And it really is an interesting study because it went and captured individual patient data from the major studies that were conducted in small vessel de novo disease, comparing drug-coated balloon angioplasty and drug-eluting stent implantation. And we see the Bello study, which was conducted by Dr. Latib. So Bello in Italian means beautiful. So basket small 2 and Piccoletto 2, which was conducted by the German group, Basket Small 2 and Piccoletto 2 by Bernardo Cortés, and then the Restore SVD China on the right-hand side, which is for target lesion failure outcomes. And what you can see is really, if we focus on the left side of the Andromeda study, you can really appreciate that there is a lower risk of major adverse cardiovascular events among patients that do paclitaxel-coated balloon angioplasty in small vessel disease when we compare them to straightforward routine drug in-stent implantation. So I think these results are really, really important, and pulling
Other thing
all of these studies,
yeah, I would stress, right, maybe is the curve seem to still be separating at 3 years, okay? Which is also fascinating, right? We talked last week about how you look at um, stents, and there's this increased event rate over years, like 2 to 3%, right? There still is with the drug-coated balloon arm, but maybe it's slightly flatter than it is with the stent arm, and the two are separating even more as we get to 3 years. So I think that's fascinating. The whole concept of leaving nothing behind. I really believe. I mean, this was my first interest in drug-coated balloons, was really small vessel. I still think this is probably one of the best indications. And to me, if you want to do de novo disease with drug-coated balloons, this is where you start. You start with small vessels. It's more forgiving. It's how you learn to use drug-coated balloons. And you do this before you do large vessels. And you get really good at doing it before you do large vessels. So I'd say that's the one thing. The other thing that's worth noticing is, like, even though these are 3 randomized studies and we put individual patient data here, it's still, each of these studies is small. Together, it's 1,154 patients. We right now are doing randomized studies in the United States to get approval for de novo disease. And each of those studies, the sample size is anywhere between 800 and 1,200 patients, right, for one study. So I think finally now we will have really good data on small vessel disease in well-powered, large randomized studies.
yes, no, absolutely. So, and this is, I think, one of the key aspects. So you guys managed here to pull out these patients, but your primary endpoints in this randomized studies were actually angiographic. So I
Except
think
for
this is
basket small. Basket small
yeah,
is clinical, but it's still, it's only 380 patients per group, right?
yes. So I think this study finally gives us a little insight of what could be actually then the results of just single randomized large high numerosity studies that are undergoing right now. Um, Let's see just 1 second. So those are results from the randomized studies comparing DES and DCB. Then there are results from also single arm studies, which have been studying not paclitaxel-coated balloons, like in the Andromeda study, but rather sirolimus-coated balloons. So this is the East registry, which included more than 2,000 patients with 2,440 lesions. And data been published up until 2 year follow-up right now. It's very, very promising in terms of, you know, safety and efficacy. And whenever we look at the nature of the lesion, well, what we see is actually, and this is definitely expected, when you look at in-stent restenosis, there's an accrual event that is really relevant. But whenever you look at small de novo disease, you can see on the right-hand side, that's the red line. We do have events, but the risk of having a target lesion revascularization after DCB angioplasty small de novo lesion is rather low, and this is a follow-up up to 2 years. So I think we should keep this in mind because small de novo lesions is really a very, very enthusiastic place where to go ahead with DCB angioplasty. And here, this is just a case example. You can see this long diffuse disease with a chronic total occlusion in the distal LAD. And this is, of course, just a case that's really maybe paradigmatic, and it's an extreme case, but it's really to reinforce the concept that we're saying. So we prepared the lesion with a 2.5 non-compliant, then a 3.0 cutting, 3.5 IVL, then again 3.0 non-compliant, just to make sure that there was that acute lumen gain that we really want to see whenever we do DCB angioplasty intention to treat. And of course, then you see we do get acute lumen gain, but then we do also get a very, very nice dissection in the mid to distal LAD. But if we look at what we discussed, I see very good flow down the LAD. Okay, I don't see TIMI 2.5 flow kind of thing. This is a TIMI 3 flow, and there's definitely some minus, but there's no contrast and gap in the vessel. And I think this was a case, it's again, extreme case, where the DCB angioplasty allowed to avoid a stent in the whole mid to distal LAD while just doing a proximal stent. You can see up there where there was more calcified and more proximal vessel.
So it avoided full, if you go back, it avoided full metal jacket, which I think is important. I think the other thing about dissections not occluding is residual diameter stenosis, right? Well, it's something we learned in the old days. I mean, Michael, you remember this, right? Is that the lower the residual stenosis in the days we didn't have stents, the lower the chance of the dissection occluding. And that still applies today, right? Is you have to have very low residual stenosis. The other thing I've noticed is, and I'm sure those who've been doing this for a long time notice that too, is the fact that somehow the LAD and the circumflex tolerates these dissections better than the right coronary artery when they're long dissections like this. I'm not sure if it has to do with all the side branches that come off and all the sort of, area of perfusion compared to the right, where it's very distal. I mean, the right's more like a conduit. There are no branches coming out until you in the PDA or PL. So whenever I've seen a dissection not progress, it's usually been on the right side than the LAD. But also, I've often asked myself, is like, we invented stents to prevent acute occlusion, right? And when you see a vessel like this, you go, oh, I think a lot of people would feel uncomfortable, especially if you look, Pierre, where that diagonal is, right? It looks pretty crappy, right? I mean, it's not like what we used to nowadays. We all used to the stent-like results that look beautiful now, but if you fill this artery up with 120 millimeters of stent, I'm not sure you're going to have great long-term outcomes. So you have to start feeling comfortable with leaving this alone. But I've often asked myself, why are we not seeing more acute vessel closure when we do de novo disease with drug-coated balloons? Because if we were, it would have killed this technology already years ago, right? Because there's some centers that do this in 80% of their cases. They're using a drug-coated balloon. So is it just they better at PCI? Are we better at PCI now? I'm not, is it an effect of the drug-coated balloon? Maybe it has some acute effect. I don't think so. I think the biggest reason is DAPT, is the fact that nowadays, compared to when we were doing balloon angioplasty years ago, okay, before stents, remember stents, DAPT only came around after stents were being implanted. The first stents that were being implanted were implanted without DAPT, and balloon angioplasty was done without DAPT. It was done keeping patients on warfarin and aspirin, and sometimes we would use even more toxic drugs to keep them anticoagulated after a balloon angioplasty procedure. Michael, you probably remember, I'm trying to think what the name of the other drug was that was used. I don't know if you remember.
It was
Or Mark.
dipyridamole.
Sorry, say that again?
Dipyridamole.
Dipyridamole. Yeah. And there was one other one that
And we
was
use dextran also.
dextran, exactly. And even dextran, right? And it was really, Colombo who was one of the first to use DAPT and stop using these anticoagulants. And when we switched from DAPT to DAPT from all these other drugs, right? Literally, you could see in hospitals around the world, the mortality from PCI like rapidly decreased because bleeding decreased by like 60-70%. So it was a huge impact. And I think it's still that DAPT that's causing preventing the acute vessel closure. Anyway, let's carry on.
So yeah, we've seen some images now, but we also try to address this issue and we try to answer to the question. So we see a coronary dissection during DCB angioplasty, what to do? So this is kind of relatively rapid flow chart. So if you see TIMI flow less than 3, well, you're not happy. You might consider bailout standing. Then if you do see persistent extraluminal contrast, well, that also might not make you happy and you might consider bailout stenting. And as Dr. T was saying, whenever we see a coronary narrowing within a true lumen, so wherever the contrast is flowing with a diameter stenosis of more than 50%, well, that might be also something that we need to might ring a bell to actually go ahead and think about bailout stenting. So I think there's multiple levels that we need to assess.
But also
And
that your data is different to what my impression has been, which is interesting. I'm learning something here. You actually say in your predictors, in the data you publish, that there's a higher risk for LAD of. Is this a high, when you say high risk for dissection, or do you mean a high risk for vessel closure?
So this is for this section, and I think the reason is that in this LAD that we included, they were very tortuous.
Okay.
And most likely what happened, we had this selection bias that LAD was diffused with very tortuous vessel. And that's kind of the explanation that I made to myself.
Okay, so it's not acute vessel. This is not a predictors of acute vessel closure.
No. This is a predictor of dissection.
Okay.
So,
all right.
Yeah. And you can really see, so the middle, we're looking at the predictors of this. On the left side, it's the incidence. On the right side, it's the outcomes. So we followed up patients here. The Kaplan-Meier curves go up to 2 years, and really they're superimposed when we look at patients with the untreated dissection and no dissection. So I think this is some data that might be actually helpful and promising in terms of if we see a dissection that we decide not to treat for some good reasons, well, we can expect at least as similar outcomes as not having a dissection. Of course, no dissection, but still having a good residual lumen and acute lumen gain. And whenever this is just another further level of interrogation of the lesion. So if we're still in doubt, if we still have we're not sure, should I put a stent or not? We have a wire down. What we've been seeing and what we've been doing for a bit was also actually to assess the PDPA. So it's very simplistic. It's just measuring the pressure distal to the lesion and pressure in the aorta. And if this is 0.90 or more, so the ratio is 0.90 or more, well, that might tell us that whatever is happening, because unfortunately we don't have endoscopy is a fabulous tool, but we don't have it clinically. We don't know what's happening. But if we see a drop of the PDPA of 0.90 or more, it means that there must be something down there that's contributing to having some kind of pressure loss. Is it the dissection? Sorry.
Yeah, no, I agree. I just want to, Mark has to leave, and I just want to answer his question quickly in the chat. So he asked, when you do 1-to-1 ratio, assume your size into the distal part of the lesion. Yes, I agree. Why reluctance to use DCB? Right? It's not that I'm reluctant, Mark. I'm completely okay with using rota after DCB. What I don't know, okay, and here's my concern, is how effective are DCBs in calcified lesions. And that's really where I'm concerned. So the thing with rota sometimes is it softens the plaque, the calcified lesion. You know, you see even when you do imaging, you can see where, because of the Y bias, where the rota passed, okay, but you may not see a fracture. You can see the burr, okay, and the shaving of the calcium, but you may not see a fracture. So it's not a question that I'm reluctant of just doing rota followed by DCB. I just think that if you have very calcified lesions, you need to we don't know how well DCBs work, but in my humble opinion of just looking at a lot of these other data and seeing a lot of cases, I think you have to get good cracks or fractures of the calcium. So, you know, do the rota, but then go afterwards with a balloon, whether it's cutting, non-compliant, really make sure you have fractures or breaks in the calcium so that the drug can get beyond the calcium. Because otherwise, that hard sort of calcium layer, right, would just be, the drug's just going to stay there. It's not going to get through calcium. It's not going to dissolve past it to get to the vessel wall. So I do think you need to debulk the calcium and break it, right, so that, and get drug past it, so that as you develop new neointima in that area, you have an opportunity to cover that area, but not be excessive. That's kind of been my thinking. The big challenge for us is it's hard to prove this because there are no animal models for calcified coronary arteries. I wish there were. So the only way to figure this out is on patients. And this may be when these balloons are approved. This would be a great study for one of our faculty or one of our fellows to do because we do so much imaging here, is to do a small study on calcified lesions with imaging and drug-coated balloons to understand, like, are there calcified lesions where drug-coated balloons work better than others. So I'm gonna leave it to you. I'm gonna leave it to you to remind us when we have these approved to maybe we can do a good clinical study. I hope that answers your question, Mark. Okay.
Okay.
So the other thing I'm just going to mention about PDPA, I think it's a great way of assessing residual stenosis and your angiographic result. It's actually one of the oldest things we've done in interventional cardiology, right? If you go back to Grunzig's paper in the New England Journal of Medicine, one of the things Grunzig mentions is that you can measure the gradient across the lesion as a way of telling that you actually had a good angiographic result. The only thing I would warn about this is if you want to use PDPA to assess your lesion, you got to put the pressure wire down in the beginning and either work on the pressure wire or leave it as a buddy wire. Okay. To put the pressure wire down at the end to evaluate in that kind of that LAD that PS showed you, I'm a little nervous about that because pressure wires are so difficult to control. They're the crappiest wires we have in the cath lab. And it's very easy if you're trying to go down a dissected vessel to sort of actually extend the dissection and make the vessel worse. So I would just be a little bit, doing the PDPA requires experience, but I think the safest way to do it is you have to have the pressure wire down the entire time while you're dilating. Don't put it down at the end. Just my word of advice. Go ahead. I think we've got a few more minutes, Pierre. We always run out of time because we talk too much. So maybe let's just go a little faster and we can see if there are any questions.
Let's try. Yes. So yeah, this is the example for the dilation, the PDPA increased, and you can really appreciate a very promising result. And it's just a way to, further way to interrogate the lesion and really be sure what we're doing. This is another example with this linear important dissection of the ostium with the diagonal. PDPA was 0.91, very distal. We decided to leave it. And also then we get to the large vessel kind of situation. So that's an indication putatively number 3. And we have seen now, and the randomized study in the Lancet by Gao, it's red cage free of all. It had a lot of resonance, but I think we can touch upon, Dr. Latib, if you agree, just upon a few key aspects of that as well. But in general, I think that whenever we are aiming for large vessels, so vessels that, let's see, so Bellows study included patient with less than 2.75 of diameter. So anything more than that, we can consider large vessel or at least non-small. But I think to target those kind of lesions, you really need to have long disease. And this is a study from the group with Eccleshall. They really got to see results on patients, all comers with any kind of vessels and de novo lesions. The proportion of patients with vessels of 3 or more was pretty high. And you can really see that up to 5 years follow-up, there were no differences between the 2 cohorts of DCB and DES treated patients. I think this is really promising, but still, I think we need to target long lesions. There is no point in targeting a focal 8 millimeter lesion at proximal LAD 3.5 with a DES in a stable patient with normal play. I think we have great results there with DES, and I think there's really no point. And you can see that if we look also in all this context of the red cage free data in small vessels when compared to the other studies, the report outcomes are very much small and very much reduced with respect to the other randomized studies in small vessel disease, but there's no difference in the small vessels. So red cage free actually showed that the incidence of the major composite endpoint at 24 months was about 6% in the drug-coated balloon group, and drug-eluting stent group at about 3.5%. But I think there's some limitations considering also the type of device used. The wide PCB was used, which is a paclitaxel iopramide Chinese DCB. This was compared with the Firebird drug-eluting stent, which I've never heard of, but it's just really important to see that this was a large study that was conducted in China and that had some selection bias in terms of lesion selection. It was really, I believe, counterintuitive and really included the lesions that most likely will benefit from drug-eluting stent. So if we go out and just think about what kind of approach we can have, I think especially now that we're trying to see if drug-coated balloon angioplasty is reasonable in de novo lesions, I don't think we need to treat all lesions with DCBs. Because even though this might not get a difference in outcomes in terms of, DCB may be worse, it's just that it might mitigate the effect whenever we want to see actual lesions where we think that DCBs are actually better. So if we target long lesions, we target complex bifurcations, maybe also chronic occlusions, I think there's much room there to actually see the effect of DCBs in this
I also,
situation.
I would also say, though, so in all of these new technologies, there's always like I don't know, the cults or the extremists. So even with DCBs, there's the DCB Taliban, I like to call them, who believe you can treat like 90% of lesions you see with DCBs. Okay, and I honestly don't think that's the right way. I think we have to see this technology for where it works best and incorporate it in where it works best. This technology doesn't have to replace stents for it to have a role in what we do every day, right? And I think when you start going too extreme, that's when you're going to start seeing the negative consequences of any technology, right? And we've seen that before. So to me, you have a focal proximal LAD lesion, you can put a 28 millimeter, 3.5 millimeter drug-eluting stent in. There's nothing wrong with that. I mean, you're going to have we have great outcomes with stents, especially larger stents, right? When you put larger stents and they're not too long, I think, we should continue doing that. I don't think DCBs are going to replace that because the outcomes are just so good, it's going to be hard to beat. And we saw that with, when we tried to use BVS, right? We thought we had this great technology that would replace stents, and the results from stents are just so good. So I think we have to be careful. I think, this sort of pragmatic approach, is really important. Can it be just an addition to what we do to minimize putting, full metal jackets in, be able to treat patients who wouldn't be able to treat otherwise with diffuse disease, where we go, I'm not even going to try because I know they're going to end up with a full metal jacket. I think that's, to me, the sort of the more pragmatic way makes a lot of sense. Anyway, let's quickly finish up. Maybe I'll take over here quickly, just so we can go quicker. So we talked about lesion subsets. I'm really interested in these three other subsets, particularly the first two, high bleeding risk and diabetes. For diabetes, there's a lot of promising data. They're all sub-analyses of main studies where the diabetic subgroups actually did much better with DCBs than with stents. So interesting, but we don't have any large-scale randomized studies. ACS, also interesting because potentially, younger patients, softer plaques, it could be interesting. The one that probably interests me the most is high bleeding risk patients, because even though we do have now stents that are approved for 30 days of DAPT, like Onyx, there's still some patients where, even 30 days is long, right? You're really worried, will they even tolerate 30 days of DAPT? Or they need urgent surgery, in 2 weeks' time. That's where I start thinking of DCBs, because if I need to stop DAPT after 2 weeks, I'm okay with it. Okay. There's some randomized studies happening in Europe now, even looking at single antiplatelet therapy. So maybe just giving Plavix after DCB. We don't have that data yet, so I wouldn't do it. I would continue to do 30 days of DAPT if there's no new stent that's implanted. But I think, if I did a high bleeding risk patient, and I'm really worried they're going to either bleed on me or they're going to need surgery. And before months over, I like this technology rather than putting another stent in. I feel much safer if 2 weeks after the procedure I had to stop everything and I just did a balloon versus putting in a bare metal stent. Oh, well, we don't have bare metal stents, a drug-eluting stent, because we don't keep bare metal stents anymore. Next slide. I think bifurcations are interesting, particularly side branches. And could you treat, the side branch with a drug-coated balloon and the main branch with a drug-eluting stent? And I think we're going to see more data on this. The data so far is interesting, very small numbers, but I think we will see more data. This is an interesting indication. The other interesting indication is chronic total occlusions, especially when you have long dissections. Can you minimize stent implantation by just putting only one stent, maybe where the CTO was, and leaving the dissection part with just drug-coated balloons? So I think we'll see more data on that. Next slide. So I think this is where we end. I think Pierre did a great job of showing you, and I think we're trying to highlight that this is a complementary technology. It's not trying to replace drug-eluting stents. It really avoids caging the vessel and a permanent implant. Lesion preparation is the basis for this. If you don't do good lesion preparation, don't bother opening the balloon, especially at the current price of the balloon in the United States. There's some, for me, the most interesting indications are ISR, small vessels, high bleeding risk, but there are these other groups we mentioned where we need more data. And we didn't touch into too much the difference. We did last week a little bit, paclitaxel versus sirolimus. Both of those are going to be available, and I think we'll need more data really to understand, is one better than the other, or are there specific subsets where one is better than the other? So we're going to stop there. If there are any questions, we'd love to answer them, and thank you for listening. Yeah, I don't see anybody. No questions. I guess we were very thorough then.
Good morning, Dr. Latib. I have a question.
Waqas, there we go.
So yesterday we were doing a case of post cardiac transplant, and we saw a case of very aggressive allograft vasculopathy. Do you have any opinion or thoughts on using DCBs in CAV patients?
Great question. There is very little data out there. There's no published data. I've been waiting for DCBs. I think we should try. Because stents do very poorly in those patients. So I've been stenting those patients for years. They all come back with restenosis, aggressive restenosis, occlusive restenosis. So I would suggest that, we actually start doing it, but in a very controlled way, where we actually collect data and bring, the good thing about that group of patients, they come back for routine angiography, right? So you're going to get angiographic follow-up in all those patients. So we have a large transplant population at Monty. We have an amazing interventional group who does imaging. To me, this is a great clinical study that we should study internally. And I would be very supportive of us using drug-coated balloons only in those patients and not putting another stent in. But I would want it done in a very controlled way where we collect the data and we reanalyze and we look at it a year from now, right? After we've done 20, 30 patients and see, is it valuable or not? I'm not in favor of just doing things and not collecting the data. I think you have to collect the data and do it properly. This is an approved device, and I think there's good reasoning why it may be better than stents.
Awesome. Thank you.
Yeah, you're welcome. Any other questions? Asma, did we answer all your questions? Saul?
Azeem.
Yes. Who's that?
Chakra.
Hey, Chakra.
How are you? So if like I did one of these cases, we put the balloon angioplasty, and then after putting the DCB, long DCB, there was like some dissection. Do you think we can be able to go with a regular balloon after that to try to seal it and give some more inflation to try to seal this dissection, or I mean, there was no flow limiting issues. But do you think we can go back with a balloon and try to also,
Of course you can, and you should do what's safe for the patient, right? If you're
Right.
worried about the dissection, you believe it may close, you should then go with another balloon or even go put a short stent to seal the dissection, okay? Do understand, though, that when you go with a balloon after a normal balloon, after you've done the drug-coated balloon, you're diminishing the effect of the drug-coated balloon because you'll get rid, by ballooning that area, or again, any of the excipient, the drug that's there, you'll disrupt it and you'll probably lose a lot of it, okay? So you may not get the same result that you would have, if you hadn't touched it, but you have to do what's safe. And this is a challenge when doing de novo disease, and right now, honestly, I would encourage us, because the only way we learn about this is to generate data. I would encourage all of us to, when we have de novo disease, enroll them in a clinical study. Right? We're lucky at Monty, we have so many clinical studies. We have 3 right now on drug-coated balloons, 2 of them in de novo, 2 in ISR. And we're going to have 1 or 2 more in the next couple of years, right? So let's collect the data and let's learn.
Okay, so if I am doing a case in Monty, and I want to do DCB, should I stop to enroll in the clinical trial, or what should I do?
100%.
Stop and enroll?
Stop, yes, and enroll in a clinical study, take the patient off the table.
Okay, got you.
Okay, you got to remember,
No, I just want to know because I'm not very involved, so I want to know how
so here's the thing, right? A drug-coated balloon costs close to $6,000.
Yeah.
Okay, there's no specific reimbursement. We can get some money back through the transitional payment approval by the CMS in patients who are on Medicare. That's it. Okay. If the patient is less than 65 or is not on Medicare, you basically are losing money on that procedure. Unfortunately, that's the way it is. I hate to bring money into when we thinking about treating patients, because it shouldn't be a factor. But unfortunately, we work in a health system where we have to be respectful of also the fact that these things are important, right? So if you do a DCB in a patient where it's not reimbursed, that procedure runs at a loss.
So one last question. I'm sorry I asked too much.
Yeah.
Like, let's say we're doing a bifurcation left main. We want to put 1 stent and DCB. Also, you recommend to stop and enroll?
Well, that left mains are not included in clinical studies. Okay.
Not for the left main itself, for the
I'm saying left mains are not included in clinical studies. So again, I'm going to ask you the question is, you as the physician need to figure out if before you do the procedure, does the patient have Medicare? If they have Medicare, go ahead. If they don't, you really believe a drug-coated balloon is essential, you have to stop and get pre-authorization from the insurance company.
Got you.
It's the reason there's no more drug-coated. For a couple of months, it was on our shelves, but the usage has increased so much that we've been asked by the hospital to take them off. Sadly enough. Any other questions? Asma, Mark, yes, I'll see you on. Saul, any of the fellows? No. Well, if not, have a great day, everyone. Thank you for joining. I hope this was useful.
That was great. Thank you so much.
Thank you.
Thanks. Bye-bye.